All right, we'll go ahead and get started with today's AMSSM Sports Ultrasound Case Series presentation. I'll be presenting Dr. Suleman Janjua today. He is from Baltimore, Maryland. He went to undergrad at the University of Maryland, College Park. He went to then medical school at the Windsor University School of Medicine, and then he completed his residency at the St. John's Episcopal Hospital in New York, and then he did his sports medicine fellowship currently at the Henry Ford Ascension Providence Hospital in Southfield, Michigan. And currently he's serving as a team doctor for the Madonna Crusaders as well as the Walled Lake Western Warriors. And today he's going to be giving us a presentation on a suprascapular cyst of the shoulder.
So I just want to quickly say thank you, to the staff at AMSSM to give me this opportunity. And, a quick shout out to a couple mentors throughout my whole journey for sports medicine, Dr. Tariq Awan, Dr. Nicholas Moore, and Dr. Brandon Keikos. Really, really appreciate all the insight you've given me. So today's topic, as Dr. Shafid mentioned, will be on suprascapular cyst. Very uncommon finding. So I thought it was an interesting topic to choose from. So today's objectives that we'll kind of review or go over during this presentation. First of all, we'll review the ultrasound protocol for the complete evaluation of the shoulder. We'll review some images of a complete shoulder diagnostic ultrasound. We'll review the pathology associated with this case. And then we'll discuss and review some contents of a diagnostic ultrasound report that was relevant to this patient. So let's talk about the case. One second, sorry. Okay, let's talk about the case first. So the patient is a 60-year-old female who presented with right shoulder pain. She told us upon waking up, she just felt this sharp, achy pain that began without any inciting event. She reported no injuries. She denied any recent travel and or illness that could have contributed to her symptoms at that time. She said the pain had continued to progress, significantly over a few days without doing anything further. It just continued to progress to the point where she could no longer sleep. She said it hurt to sleep on as well, at which time she took herself to the emergency department. She expressed concern that, she was unable to move her right shoulder without pain symptoms, described it as, again, aching, throbbing, sharp. She rated it at about 8 out of 10 with motion. This also prevented her from being able to do some of her daily activities. She mentioned like brushing her hair, brushing her teeth, kind of picking up stuff. So that was troublesome for her. She was evaluated in our sports medicine clinic. Initial X-rays had showed some calcific deposits within the supraspinatus near the footprint on the greater tuberosity of the humerus. There was no acute fractures, no dislocations noted. An ultrasound was ordered at the time. Patient on that visit had received a subacromial space injection with a script for physical therapy and given some tramadol as needed with recommendations to follow up within 4 weeks. So on physical exam, during her visit, she did have some tenderness to palpation in the suprascapular and subscapular spaces, as well as some atrophy noted on the physical exam. I'll show an image of that later, how that looks. She had significant limited range of motion with weakness. She was limited passively to approximately 45 degrees with external rotation and about 90 degrees with shoulder abduction. She also had some tenderness to palpation at the bicipital groove. Um, and then her strength, when we tested that with elevation, it was 3 out of 5 with pain, abduction 2 out of 5 with pain, external rotation 2 out of 5 with pain, and internal rotation 4 out of 5 with pain. Impingement signs, drop arm sign was positive, although there was no swelling or visible deformities noted on the right shoulder during the physical exam. Some of the differential diagnoses we had at that time, which we discussed amongst each other, was calcific tendonitis, and I'll give some justifications here to why we kind of went down this route. Given the calcium deposit on the X-ray, the pain occurring suddenly when waking up, and the fact that she mentioned that it hurts to lay on. We also thought of adhesive capsulitis in the moment, given the fact that she had less than 50 degrees of external rotation on physical exam. She did have that pain and aching, which is kind of the first phase of ADCAP in a lot of our patients. And then she did have a past medical history, which contributed to this, I believe diabetes. And then some other causes of shoulder pain that present with the atrophy of the infraspinatus muscle and external rotation weakness include cervical disc disease, brachial plexus injury, cervical spondylosis, and of course, rotator cuff tears. So these are kind of on the list of differential cases. So this was an X-ray of our patient, and as you can see, the calcium deposits right here. She had some AC joint changes, mild and then mild glenohumeral joint changes. So let's see, we'll jump to the next slide. So now to continue the presentation, I'm going to review the ultrasound protocol of how we kind of, approach this type of scenario so it can help us further conclude what exactly is going on with our patients. We typically base it on the physician practice guidelines established by the American Institute of the Ultrasound of Medicine for the shoulder, and we'll kind of review the following categories. So the long cat of the biceps tendon, the subscapularis, the AC joint, the infraspinatus, the teres minor, the posterior glenohumeral joint, the spinal and the suprascapular notch, the supraspinatus, the subacromial bursa, the coracomial ligament, and then we'll do the dynamic evaluation. I'll touch on that as well. So typically, I'll start at the biceps tendon and have some pictures here, which I'll review shortly. So generally, before I introduce the probe and the ultrasound to the patient, I'll have them sitting on the table with their forearm in a supinated position on their lap with a flexed elbow. And I'll also have the patient do some gentle internal and external rotation while I'm examining them, and I'll kind of explain why I do this. That's a part of the dynamic assessment. But as you can see in short axis right here, I'll place the transducer as shown on the screen, and this is the picture of the short axis. You can see the biceps tendon right here. And it's important to remember to toggle the transducer cephalad to get the best picture of the biceps tendon and bicipital groove. And this right here is the lesser tuberosity. And again, this is short axis, and this is long axis of the biceps tendon. And this is the deltoid, and again, the humerus area. So, and what I'll do in each slide, as much as I can, I'll kind of explain what the ultrasound report showed us for these structures, and then I'll go over the full ultrasound report at the end. So for the biceps tendon, there was no tear inflammation that we appreciated on exam. And then so again, before I jump to the pec tendon, as I mentioned, I'll kind of have the patient externally and internally rotate so I can examine the full biceps tendon to appreciate any tears, coracoid impingement, or subluxation. I think this is vital to our exam when we're reviewing the biceps tendon. So from there, I'll move over to the pec tendon in short axis and long axis. And this is short axis right here. So you can see the pec major and right there, and the humerus right there. And then this is long axis, short axis. This is the deltoid. This is the bicipital groove, the biceps, and then the pec major from this view. So after reviewing the biceps tendon and the pec tendon, I'll typically proceed to the subscapularis tendon. I'll instruct the patient to place their arm in full external rotation. I usually like to use the coracoid as a baseline, like bony landmark when I'm doing this. In cases like this, it can be challenging because the patient did have limited external rotation. So I had to kind of, help her passively get to as much as external rotation, view the full subscapularis tendon. And again, this is subscapularis and long axis. And I've labeled here for you guys right here. You can see the subscap, and this is the lesser tuberosity. And this is me viewing the subscapularis and short axis. This is subscapularis and the humeral head. And then with the patient in the same position, of course, this image right here, you can see it shows a hyperechoic fibrillar subscapularis tendon. The hypoechoic area is seen in the region of insertion, and it just kind of represents some anisotropy. Again, that's not pathologic, it's just the way the probe is being toggled. And then right here, I have a full view of the subscapularis tendon when we were scanning. And so from proximal to distal, Again, it's important to do this a few times just to make sure that, there aren't any tears, there aren't any inflammation or tendinopathy signs for this. So I thought that was a good video to share with you to get a good example of how to view that. The next structure that we move on to from the subscapularis is the AC joint. And again, the X-ray had shown some arthritic changes or degenerative changes, which were, reflected on the ultrasound. Typically, we'll look at the AC joint to evaluate for any separation, capsular disruption, arthritis again, or impingement with the patient's forearm. As you can see in this picture, and hand laying, usually have their hand laying on the ipsilateral thigh. And then this is important to visualize because again, these subscapularis cysts, at least from the research or literature that is out there, this is one of the origins or the sources of the suprascapular notch cyst. So they typically say it's either from AC joint degenerative changes, or it's from like the labral tear or capsular trauma. So right here is the AC joint they're showing you. And then this is the fibrocartilaginous disc in this place right here. So these are good examples on this image that I had. And again, our AC joint ultrasound showed some moderate degenerative changes on the report. Then I'll kind of transition over to the subacromial bursa, and then I'll move the transducer laterally right here in the coronal place over the proximal humerus beyond the greater tuberosity to assess for any fluid within dependent portion of the subacromial subdeltoid bursa. The ultrasound image shows here, so nothing significant, but it, kind of just examine that further, just to rule out any further, diagnoses for this patient. To dynamically assess for subacromial impingement, the transducer is positioned in the coronal oblique plane, right here, coronal oblique plane to visualize the lateral border of the acromion and the adjacent greater tuberosity. Assess typically the supraspinatus tendon and the subacromial subdeltoid bursa dynamically first by passively abducting the arm, typically with the elbow remained in flexion. The movement is then repeated, and then any subsequent pooling of fluid will give me an idea or bunching of the subacromial subdeltoid bursa if there's any impingement. I have a gross picture here too, so the acromion, I've labeled the deltoid, and so the bursa, the humeral head, and the supraspinatus, and this is kind of pointing to the bursal area. So moving forward, after evaluating the subacromial bursa, I'll typically have the patient transition to a position where their shoulder is extended, the elbow is flexed, and the palm of the hand is kind of against their back pocket. This position is called the CRAS position. It gives us the best view of the supraspinatus when we are examining it. And again, I've reflected this in long axis and short axis. So upon transitioning to the CRAS position, the goal when imaging the supraspinatus is to evaluate it in both of these axes. If the tendon isn't visualized in the CRAS position, and some people may do it in a neutral position, the challenge they'll typically face is while the distal supraspinatus and related pathology can be seen, more proximal pathology may be not as visible due to the shadowing of the acromion. So that can be, kind of a barrier in our diagnosis when we're trying to look for one. So upon transitioning into the CRAS position, I'm scanning the supraspinatus. It should be continued anteriorly along the greater tuberosity until the intra-articular portion of the biceps tendon is identified to ensure that the anterior extent of the supraspinatus, which is evaluated, that's where the supraspinatus tendon tears commonly occur. And then the supraspinatus and long axis will show us a hyperechoic fibrillar with a convex superior margin shown at the level of the superior facet right here. Some structures, supraspinatus, the superior facet, and this is just anisotrophy. I wanted to label that so we can see based on the toggle, and then the humeral head. And then in short axis, we see the supraspinatus, the humeral head, and then we can see the biceps right here and the rotator interval. So After assessing the supraspinatus and long axis, the transducer is turned, uh, we'll turn it in a posterior angle. So right here, superiorly toward the humeral head, parallel and just inferior of the scapular spine. From here, this will help us visualize the central tendon of the infraspinatus muscle at the musculotendinous junction, posterior to the glenoid. The transducer can then be moved inferiorly to visualize the small teres minor. Right here, so infraspinatus and teres minor. Again, this is short axis with its tendon more superficial over the muscle compared with the infraspinatus tendon. The transducer is then turned 90 degrees, and at this point, we'll evaluate the infraspinatus and teres minor. In long axis, the infraspinatus muscle should be nearly twice the size of the teres minor over the scapular body, with normal muscle appearing relatively hypoechoic compared with the hyperechoic tendon. Again, these are the images in long axis and short axis right here, and I've labeled the structures. So then I'll scan over the posterior glenohumeral joint for evaluation with their hand on the contralateral shoulder to look for any sort of effusions, Hill sacks, or labral pathology. And in this slide, I have a few pictures, which I think is one of the most important slides. So right here is the glenohumeral joint. This is the posterior glenoid labrum, the glenoid here, the humeral head. These are neurovascular bundles. This is the subglenoid notch and the glenoid. And this is the scapular spine. And this is the suprascapular notch with neurovascular bundles. And this was the cyst we appreciated, kind of the nerve line running through there, which was compressed, which is the reason that the patient did have the pain and weakness with those certain movements. The ultrasound report showed a hypoechoic cyst near the suprascapular notch. No discrete tears, mild tendinopathy. This is a picture of the atrophy and how that would be appreciated on physical exam. So the case ultrasound report, again, the location, right shoulder, study type, diagnostic, indication for test, the right shoulder and pain and weakness that the patient expressed. Comparison, none from previous. Transducer we used was the linear mid-frequency. And then the findings, again, I'll kind of review the report. Biceps tendon, there was a normal fibrillar appearance, no inflammation or tear appreciated. Subscapularis without any tear tendinopathy, mild distension of the bursa. The AC joint, showed some narrowing of the spaces, so degenerative changes. The supraspinatus showed a hypoechoic cyst, which we appreciated in the previous slide, near the suprascapular notch, no discrete tear, mild tendinopathy, infraspinatus without tear tendinopathy, and then some atrophy of the infraspinatus muscle, which kind of, justifies the patient's clinical exam. The labrum showed a smooth, well-defined edge with consistent echogenicity. There was no tears. As far as that goes, the posterior glenohumeral joint showed no fusions. Teres minor was normal and without any pathology noted on the ultrasound case report. So typically the treatment plan for a patient like this, they were initially treated, as we know, with the subacromial injection, given a script for physical therapy, and then tramadol is needed for pain. They followed up in 4 weeks. They returned, continued to express pain, symptoms with weakness. At that time, they were given a referral for MRI and EMG with confirmed suprascapular notch cyst and suprascapular nerve palsy upon their scans. So at that time, patient was scheduled for arthroscopic decompression, which was successful, no complications afterward, and they were recommended to continue physical therapy for approximately 6 weeks. So just some conclusions as far as this case goes. On ultrasound, again, this type of cyst, uncommon, though it will show up as a well-defined fluid-filled structure with an anechoic content. On MRI, the cyst will appear as a fluid-filled mass, showing high signal intensity on T2 weighted images, indicating a cystic nature. Increased T2 signal within the affected muscles may be seen, signifying muscle edema due to nerve compression. I did talk to the surgeon and the staff, and they also said that sometimes, even if you're not able to make out the cyst too clear on the MRI, when you're approaching when you're approaching the procedure, sometimes as soon as you advance the needle, you'll see a splash of fluid, and that kind of is also reflective of the fact that there was a cyst there, which was compressing the nerve. So, ganglion cyst in the shoulder region, they're either, again, from trauma to the capsular tissue, labral tears, or adjacent joint pathology. And then just to kind of discuss the procedure because the conservative management didn't work. Even though some of the surgeons say that some of these cysts will just dissolve on their own after a couple months, so this is not always the route to take for a patient like this. However, if it does come down to it, we do an arthroscopic decompression of the cyst, which is considered the diagnostic evaluation if the specific criteria are met. So you do this typically if the EMG demonstrates evidence of the isolated compression of the inferior branch of the suprascapular nerve, combined with an MRI evidence that the cyst was greater than 1 centimeters, and I believe for this patient it was about 2.5 centimeters. And it's of course located in the notch. So these are some references which helped me with the literature. So I wanted to kind of pay respect. And then that's all for my presentation. Appreciate it. Any questions or comments?
Really good presentation. I thought it was very insightful. I especially liked how you mentioned the physical exam findings that made you include certain things on your differential, and how you walked us through the ultrasound reports and what findings it correlated with on physical exam. Great presentation. Thank you.
Sure. I appreciate it. I think this is one of those diagnoses which is kind of if it's not something we're thinking of right away, we do have to rule it out. And we so commonly see, at ADCAP, we so commonly see calcific tendonitis that this is not always in the back of our mind. So I think those are good routes of thought to take when approaching something like this.
Yes, thanks again so much, Solomon, for going through the presentation. Just kind of a couple of thoughts and comments to kind of bring up for it. I think, when we're always going through these, presentations and the scans, we really try to think about the protocol and, what are things that we can kind of add in for this that are going to be helpful. What are things that you don't always have to include? And this is definitely one of those kind of tricky areas for the shoulder because it's posterior, and so a lot of the more structures that we're scanning for the shoulder are going to be anterior and lateral. And so, yeah, it's usually trying to figure out, is this going to be a complete shoulder protocol, or do you have to kind of add in a few things? And I definitely would recommend, doing the complete shoulder protocol like you had demonstrated, just to rule out any concurrent pathology, even though this is kind of what you're thinking for your diagnosis. But two things that I think are sometimes helpful to add in if you do think it is this cyst is, taking a look at muscular atrophy in the area, especially. So we kind of talked about this a little bit last week with a common peroneal nerve case. But if you have any type of nerve pathology, it can be helpful to then look at the muscles that are specifically innervated by that nerve to see if there is atrophy associated with it, just because obviously those can be associated symptoms. So this would one be, I definitely would look at not only the infraspinatus, but the supraspinatus, as well too, just because if you're at that suprascapular notch, that's going to be something you guys will even see on board purposes as well too, that's one that will affect both the supraspinatus and infraspinatus, where of course, if it's just at that spinoglenoid notch, it's only going to be affecting the infraspinatus. So it definitely can then help to differentiate, where the suprascapular nerve is getting affected. So I definitely would, probably take a look at muscular atrophy of the supraspinatus as well too, which may or may not be present just depending on the extent of the nerve injury, but probably just still something worthwhile. We're talking as well too. It is a little bit hard to differentiate though the severity of the muscle atrophy. So usually it's kind of, presence there or not, but you can always do a comparison side to side as well too, which can be helpful. And then along with that, I mean, the only other thing I might include just for someone having symptoms like this, especially if you are concerned about a cyst, it would be the only other place would be like the quadrilateral space as well too. If they're having symptoms that are going more out to the lateral side of the arm or fitting an axillary nerve distribution, just because rarely you can also get cysts at that area. So obviously that's going to be a little bit more advanced scan, but something that if you're concerned about a cyst, the three main areas are going to be the suprascapular, spinoglenoid, and then the quadrilateral space. And then in addition at that area, you can always look once again for muscle atrophy, just because that if it is affecting like the axillary muscle group, such as the deltoid or the teres or the subscapular nerve, those are going to be kind of different muscles that you'll see differentiated there. So those are the kind of main things I would think about just from the protocol standpoint. The other thing is then for the actual pathology in this case, you had mentioned in kind of your description of the cyst, typically being an anechoic cystic mass. Other things that you can include just to kind of complete the description of it. Usually then these are of course going to be non-compressible. However, I will say usually that's more apparent if they're superficial cysts. This is definitely one area that it's fairly deep. So even though you can do the sonopalpation with the transducer. It may be difficult to fully demonstrate that, but sometimes even doing movement of the shoulder too can cause some of that additional compression, which can be helpful. But then the two other things I would add in would be vascularity, at that site as well too, just
Doppler.
because you can have vasculature in the area. But doing color Doppler on that region can be helpful just to kind of rule that out. And then lastly, typically those cysts, which were demonstrated actually well in your images, is that you can get posterior acoustic enhancement at that area as well too. So once you kind of add all those factors in, you're going to be pretty certain that it's going to be then a cyst at that area. And one thing I actually wanted you to go back to your image of that cyst, because I think it actually shows it fairly well. When you're looking at that suprascapular notch, on the image there. So you see the cyst fairly well. The nerve actually in that image should be in a short axis view. So you should be seeing it almost as a honeycomb appearance as it's diving through the suprascapular notch. So I actually think you're picking it up on the right side of the image in that location that you see a kind of little circle and kind of hypoechoic area. And that then is kind of demonstrating, I think, fairly clearly that you're getting distension and compression, of that nerve at that location. So it's actually a fairly good image. I was just realizing that in that image, typically it's going to be a short axis rather than a long axis view of the nerve kind of, diving through. Um, the only other things I was going to bring up for pathology, you had mentioned, yeah, cysts are very uncommon, in this region. But of course, this is where ultrasound can be really helpful to evaluate. As well too, always can get MRI for further confirmation. But the other typical pathology that you'll see this with, as you had mentioned, is going to be AC joint if there's a lot of degenerative changes at that area. But the other that I'll actually see most common for suprascapular neuritis or neuropathies will be some type of massive rotator cuff tear, just because in that region it can actually cause some traction on the nerve just with the tear if it is fairly large. And sometimes that can further cause irritation of that suprascapular nerve. And differential wise, I think you're very comprehensive with it. The only thing I would add in would be Parsonage-Turner syndrome, just for someone who's had atraumatic shoulder pain. That just kind of comes on very suddenly, especially in the shoulder region, and if it is affecting different, muscle groups. But that's where I think it's helpful then to go ahead and get the EMG like you guys did in this case, because it can be really used in conjunction with the ultrasound. And I think this is a case that demonstrates that very well, is that you can fully confirm the severity, I think, of the nerve injury with a nerve conduction study and rule out other nerve pathology. But then the ultrasound is extremely helpful to demonstrate anatomic issues that may occur with that nerve, such as compression, that won't be able to be answered by the EMG. So then in this case, you're really to use those two modalities together to confirm the specific diagnosis diagnosis for this patient and come up to a set treatment plan. As you had mentioned, then these ultimately can be arthroscopically, removed, which definitely can be the definitive treatment. In some cases, you can even aspirate these, as well too, and inject at that location. But obviously, I think it just depends on the size of the cyst as well as just how deep the cyst is in that area. I definitely think something that you can consider as well too with ultrasound guidance.
Thank you. That was very insightful, and I appreciate your feedback, and I'll make sure I implement that moving forward in my exam. And typically, like this protocol, we try to utilize it on majority of our patients. Just presenting with shoulder pain, so that way we do not miss anything. So I think it's a good way to practice, and there can always be something missed, and if you're examining everything, that kind of gives you that reassurance or peace of mind at the end of the day that you're not going to miss out on anything when you're trying to help the patient. The only other differential I think we discussed that I didn't put on here was hereditary nerve disorders, because the patient actually had some problems with like the common peroneal nerve, and she had some other nerve related issues. So but the fact that she was having the pain and weakness initially, they also had considered that as one of the differentials. But I don't know if that was too relevant with this case, but it definitely was a part of our thought process.
Yep. Yeah, I think that's important to include. But once again, another reason that you get that nerve conduction study, and that's where it can be helpful, in conjunction, with this as well too. So I always just say they're not competing modalities. You don't have to say one or the other, but I think using them together can be extremely helpful, like this case demonstrated. So. All right. Well, otherwise than that, I don't see any other questions in the chat bot. So I think that we'll go ahead and conclude today's presentation. So once again, thank you so much, Solomon.
Thank you guys. Have a great day. Bye.